Mr. Praderio, who many of you probably know, who will be discussing medical comorbidity and Alzheimer's disease. And Dr. Praderio also hosts a monthly face-to-face support group, so we would invite you to participate in that as well. Dr. Praderio.
Thank you. Thank you for inviting me. The medical comorbidities of Alzheimer's disease and dementias in general is such a poor research and evaluated situation that in general I review approximately the last 10 years in the most important papers, clinical trial, and some research. And honestly, we continue having this parallel that has been the prevalence of how we approach individuals with dementia. And when I refer to the parallel is, if you are a geriatric psychiatry or a psychiatry or a neurologist, take the pathway of thinking about the dementia and the cognitive deficit. And if you are the primary care physician, you think about diabetes, COPD, obesity. But there is not a crossing line, there is not a balance between these. Therefore, it's difficult, it's very difficult, and we will try to do the best today. And I want you to be interactive. If in any way you have to stop me, just do it. We will start with our working agenda. We will define a little what is dementia, a little part of the diagnostic criteria, some of the different type of dementias, because individuals always ask me, my mother have dementia or have Alzheimer's disease? And today we will know this. Dementia is the neurological disorder, and Alzheimer is one of them, but maybe others. And we will look at the comorbidities specifically. If we go and interview individuals in any venue, on the street, in a park, and say, tell me one of the symptoms of dementia, the individuals will say memory loss. Because that's the way the dementia has been portrayed. Dementia is a lot more complex than just memory loss. Dementia have problems with the speech, with language. Therefore, this is called aphasia. And the individual have word-finding difficulties. Dementia have difficulties with fine motor movement and coordinations. They have difficulties with a remote control of buttoning their shirt. And this is called apraxia. And then there are difficulties in recognizing objects that we grew up and we knew it. And we want to set the bottle of water and we say, can you give me this, the thing on the table? Because we cannot produce a name. And in addition to all of this, dementia have deficit of executive functions. Those functions, these are programming our life and letting us to behave appropriately. Therefore, it's a lot more than just memory. And when we go in diagnosis, for those of you who are clinician, we have the memory impairment, the aphasia, the apraxia, and the nausea, but we have a specifically disturbed executive function. These are the ones that interfere and create problems. Now, let's talk about different types of dementias. Approximately 60 to 62% of the dementias in the United States are Alzheimer's disease. And that form can be divided in the majority, 80%, are late onset of Alzheimer's disease. And there is a percent of about 12 to 15% these are early onset of Alzheimer's disease. These are the one marked with familiar connotation. And the second one is cerebrovascular disease, is vascular dementia. And they run very close to a mix of Alzheimer's disease with Parkinson. This may go to one lateral and be a Parkinson dementia, or might be the very well studied later on called Lewy body dementia. This is a very difficult dementia to treat. And then we have others in less percent. And a little of the clinical course, because it's important that we have a base for what we are going to talk today. Memory loss become affecting the everyday living. It's not just that we forgot the keys and we cannot find it, and this happens twice a month. It's a memory loss that's really interfere with your living condition. Interfere because you go to the supermarket and you forgot the list and you just remember 2 things out of 7, and this is getting in your way. And there are difficulties performing familiar tasks, specifically those that we learn and they are so common to us. For example, we can remember the content, specific content of a recipe by remember the components of the recipe. But then when we start trying to bake the cake or to bake the bread, we have difficulties in the way that they are coming together, and we end up with a mess because we are missing one another. And like I said before, problem naming objectives we knew for a long time, or getting lost in familiar places. Honestly, this happens very frequently. This may happen even for a while inside your own home, because you get up during the night, go to the bathroom, and then you have difficulties getting back to your bedroom. And sound like, wow, but this is a really advanced dementia. No, not necessarily. And the judgment decrease or decision-making abilities are being deficient in our abstract thinking and the way that we has been learning and that we grow up start disappearing, and we make decisions that are erroneous. And then there is change in mood and in behavior, and those are more or less the clinical course of the disease. But today we are in here for a different reason. We are in here to see if we can obtain at the end of our conversation a better idea how important it is to take into consideration this Alzheimer's disease evolved in a bunch of years. This is approximately between 7 to 10 to 12 years. But you know what? The chronicity and progression of the disease is linear, meaning from here to there through the years. But what we don't talk is how much influence in this linear progression of the disease may create the impact of other comorbidities, and vice versa. And that's what we are going to dedicate a few minutes. Alzheimer's disease, as well as other dementia, also have clear association with serious medical problems. And the most common factor that associate dementia with medical deficit is aging. Because through the process of aging, we increase the risk of developing dementia. At the same time that we deteriorate our conditions and we have several medical syndromes. And the medical conditions require treatment. And many of the treatment, we can name medications for medical condition, can really worsen the dementia component, the cognitive ability. And these are wonderful papers supporting this. Likewise, dementia can deteriorate and complicate medical condition. How? Individuals with dementias have poor compliance with recommendation for medical issues. They don't respect a diet when they are diabetic. They have difficulties in taking the medication. How many times they end dehydrated because they don't drink appropriate amount of water. Therefore, we have all of this evidence. Every day I pull a caregiver today and I say, is this true? And they say, no, for the last 20 years it's true. But we don't talk much about this. We don't talk about unifying this. The patient go to the doctor and return with such medication, and go to the geriatric physician and return with this medication. But let's see if we can make this coexistent. Now, we want to know a little about what prevalence, what is the percent the coexisting medical condition get together with dementia. But you know what? It's very difficult to know this. And the information available is very poor. Some of the reason there is poor diagnosis of Alzheimer's disease. The 4.5 million individuals that we claim with disease are a lot more than 4.5. Therefore, in medical fields, they have a very restricted approach in entering a diagnosis of an Alzheimer's disease. Therefore, the documentation is poor. And the most important one in clinical practice, if you are demented, you complain less than a regular individual about medical problems. My demented individuals come, my patients, to see me and sit across the desk with a decompensated COPD wheezing and needing oxygen. And they are just happy that they are visiting me. And this is nothing wrong. We need to conceptually understand this Alzheimer's disease patient have less abstractions in understanding how to complain about physical problems. And thus make the outcome of prevalence more difficult. We don't know, they don't report it. I will give you some example of coexisting medical condition with dementia. And I promise this I won't bore you with the microscopic details and the hypothesis, but hypertension and Alzheimer's disease are together in 52% of the cases. Therefore, dementia carry a diagnosis of hypertension half of the time. And it's interesting because if I ask you, maybe you say high blood pressure. And high blood pressure is a long-term risk that occurs at early age, starting late 30s and 40s. But the most concomitant difficulties of hypertension is not hyper, it's the hypotension that occurs after age 65. Some of them are iatrogenic, produced by no good close control of treating someone for hypertension and putting in so down they become hypotensive. And why this is interesting? Because there is a hypoperfusion of the brain and thus deactivate some of the neuroprotective function of the brain, and the decay of the disease, Alzheimer's specifically, start taking place. And about 30% of Alzheimer's disease patients have coronary artery disease and closely associated congestive heart failures. Look at how serious, how high is the percent. And look at those two illness, medical illness, have very important support in having a clear treatment and a very compatible follow-up. You cannot fool around with digitalics. You cannot stop taking digoxin because you get in big trouble. And when you are demented, you don't take it, or you take two, or you miss two. Therefore, look at not just the actions of coexistence, if not the complexity of not having a better understanding in general how those things live together. Diabetes, 22%. And I will elaborate a little more about the hypothesis behind hyperinsulinemia, meaning the level of insulin peripherically increased to a point that doesn't allow the crossing of the brain barrier. And with no insulin on the brain, there is no pumping glucose into the cell. Therefore, the neuronal cell is being deprived of the number one nutrients that they have. This is glucose. And the deterioration starts occurring. And osteoarthritis have wonderful studies. And you know that one of the cohort clinical trials show that they are studying individuals with low bone density. And they have a cohort and they follow them and compare with individuals of the same age with normal bone density. And the outcome study is that up to 25% of osteoarthritis with propensity for fractures have a higher risk in developing Alzheimer's disease. Therefore, what you learn today, do you have to take care about B12 and about all of the good food that we talk and protecting our brain? But if you do not protect your osteoarthritis, you will be increasing 3 to 4-fold the probability of developing a disease. I want you living today and learning that doesn't mean this because you are demented you get osteoarthritis. No, I want you living today with a coexisting understanding that having osteoarthritis can create an acceleration on the risk of dementia. COPD up to 18%. Thyroid disorders by being up and lower. But specifically, thyroid disorders are one of the most benign in this constellation because are the ones that if you correct the cognitive dysfunction. Think that doesn't happen with other. In cancer, that we will have a minute to elaborate about this. About 11% of dementia are associated with cancer. But you know cancer has been demonstrated in several studies. This is a protectant to the brain not to develop Alzheimer's disease. Right? But cancer is associated up to 12% with vascular dementia. Therefore, the pathology of dementias make the difference. We will take an example of one medical disease, and run for a little while. In the United States, about 46 to 40% of individuals over age 55 develop an Alzheimer's disease. Not all are lucky to be diagnosed, but they develop the disorder. And 26, 27 million of America have diabetes, and close to 80 millions are pre-diabetic, some of them not very well worked up or follow up appropriately. The cost for the cure, the treatment, and follow-up of diabetes is approximately 174 millions in healthcare. And for these 5.4 millions America with Alzheimer is about over $180 billion. Therefore, look at the incredible amount in dollars that are being dedicated, but even the figures shared in here an assumption that the budget are being calculated separately. Maybe if we cite these two together and we have a precondition in our brain of coexistent disorder, we can prepare treatments that are going to be less costly and more beneficial. How we define diabetes as a disease when the body fails to produce or fail or properly use insulin. And you know the Alzheimer's disease is a degenerative disease of the brain. The pathology is characterized by amyloid plaques and fibrillary tangles. We question and say, does diabetes increase risk for Alzheimer's disease? In 1999, there is a nice study in Rotterdam, and they clearly discovered the association between diabetes and Alzheimer's disease. And the study concludes this: individuals having diabetes almost double the risk of developing the dementia. Question this is just mine because the study doesn't elaborate much. What dementia they develop? They develop Alzheimer or vascular dementia? The answer is both, because diabetes mellitus is a risk to develop cardiovascular disease. And diabetes mellitus is a risk to compromise peripheral vascular disease, as well as a risk to compromise vascular circulation of the brain. And we continue, does diabetes increase the risk? It's clear link with memory problems in elderly. And that was published in a wonderful paper of the Archive of Neurology, in which one they show clinical trials in which one the diabetic population have deficit in cognitive function. And by the way, similar papers were published in which one poor control of blood glucose were wonderful predictors in the decay of cognitive functions. Therefore, when they evaluate blood glucose control in mini-mental state examination, checking function of the brain, they found an association. The poorest control that you have is the higher will be the assertion of having memory problem. In the latest, the City College of New York discovered that there is a single gene form common link between the two diseases. This is up for further study. This is a gene that has been found in many individuals that present with Alzheimer's disease. And the problem is that really affect the insulin pathways and distort some of the metabolism. I am just talking about one medical illness that we decide today. Now, there is a little prevalence of coexisting condition in Alzheimer in non-Alzheimer cases. And when I say non-Alzheimer cases, we are talking vascular dementia, Parkinson dementia, other dementia. Osteoarthritis, COPD, diabetes, and cancers are very much spread, with the exception that I shared with you. Cancer appears to be more protecting for Alzheimer than for vascular. But heart disease, stroke, cardiovascular disease is much higher correlated with non-Alzheimer disease, meaning with vascular dementia. You know that. You know that post-stroke dementia is more vascular in characteristic. A little of clinical finding, just return to what we do every day. It is true, very true. The Alzheimer's disease debilitates an individual in cognitive function to the point that the individual will be influenced to present themselves with less recognition of medical problem. Please, we know that this happens every day. Even they have a different threshold for the report of pain or discomfort. They may cry and have insomnia instead of saying, I am hurting. Now, do we know after today and for a long time that many physical health factors contribute to a cognitive decline? No doubt, you just shh. So, and I show you, this diabetes mellitus have an important impact in how your cognitive function deteriorates. And there are nice studies between 1994 and 2004 showing that the higher is the comorbidity from the medical part, meaning the most medical problems you have, is very well associated with lower cognitive function, and is something that is well documented. Well, why are we interested in comorbidity? Why we are talking about this when we can be spending the day talking about why we don't have a cure for Alzheimer's disease? Or why we don't have a cure for diabetes mellitus? Or for cancer? Or for other disorders? But I think why we are interested in comorbidity is because honestly, we have been making very erroneous approach in developing treatment plans of individuals with this complex coexistence problem. In general, the choice of a medical treatment failures may occur frequently, conditioned by other factors. This is not the disease itself. Because honestly, you can teach someone healthy diet for diabetic control. But if the person doesn't have cognitive ability to remember, to follow up, to prepare the food, and to have the deep concept of the seriousness of the diet, the treatment will end up with a failure. Concomitant, and listening, because caregivers of individuals with dementia see this every day, concomitant medical problems reduce the independence of individuals with dementia. And you know what? And if this is not serious to take into consideration, when we say that we don't have treatment for dementia, but we manage the disease, And some of the management is to increase socialization, integrate them back to the society, work very hard for them to be active, but they are sitting in a wheelchair with a stroke. Therefore, please, the association that define comorbidity has to be clear in mind in order to develop acceptable treatment plan. And then a significant proportion of patients with dementia are exposed to the effect of medical medication that they need. Specifically, those one under the chapter of anticholinergic medication. Medication that they need to take because they have a prostatic dysfunction. And they take Ditrol because they have incontinence. And Ditrol is horrible anticholinergic medication for the brain of a demented individual. Create confusion 2 to 3 hours after taking Ditrol, increase the confusion immensely. Therefore, this is why we are interested in comorbidity. This is why we want to just approximate the parallel that we this morning opened when we talk about a disorders named dementia and multiple medical conditions that surround parallel. We need to stretch this and we need to bridge this in order to have a better understanding in how we develop concise and solid treatment plan for our patients. How we conclude? The physical comorbidity of the elderly population of the United States make an important contribution to cognitive and functional decline, specifically in those with Alzheimer's disease. Our review today conclude that people with Alzheimer's disease may underreport common symptoms not related to dementia. And we need to be better observant, and we need to work more with caregivers and family members. Nevertheless, we are interested in reducing costs. The important subject of the day, increase quality of life for those individuals. And if you increase quality of life, the payoff is to decrease some of the burden in caregivers. Therefore, that is kind of conceptually defining these medical comorbidities with dementias in general and with Alzheimer's disease. We cannot treat on the back end and continue pursuing the parallel because we will be missing the point that who we treat is a human being and that we need to approach holistically the best development of a treatment plan for what they are suffering. One more time, thank you for inviting me. And we are going to open the floor for any questions, and even you can adventure a little into any questions about dementia too, because that is part of my life. Thank you again. Yes.
Can you touch a little bit on the correlation between bipolar disorder and Alzheimer's?
There is a clear correlation and well-documented comorbidity between Alzheimer's disease and mood disorder. Mood disorder is a big open chapter in which one involves major depression, depressive disorders, NOS, some dysthymia and cyclothymia, and specifically bipolar disorder type 1 and type 2. The most important mood disorder correlated with Alzheimer's disease is measured depression. And the second most important is bipolar disorders. In both of them, we hypothesize are both related for the neurotransmitter dysfunction that occur in mood disorder, specifically serotonergic and norepinephrine, and some repercussion over the neurotransmitter. This is the most important one in Alzheimer's disease. This is acetylcholine. Therefore, there is a disbalance, neuronal disbalance, and appear less in schizophrenia than in mood disorder. Schizophrenia, a chronic mental illness, has deficit of cognitive function, but not similar to dementia. They have cognitive deficit of short attention span. They have an overall loss of memory. This is not a specific short term. And they have poor concentration. This is more or less the characteristic. The most important ones are chronic depression. Any other question, please?
Doctor,
Yes.
can you tell us a little bit about your office, your new office, your services?
A little about me.
Yes. Yes, please.
Well, we will make it short. At the mid of 2012, I became slowly more involved with the healthcare reform, between parentheses, Obamacare. And I did it with reticence and with a cautious optimism that 1 million of people in the United States will have insurance. But maybe 1 million of other people will have headaches in dealing with this system. But honestly, instead of digging my heels, I become very involved. And I become very involved as much as possible local, but a lot of more in my specialty in a national level. And I knew this, if we don't move, a rock will move us. And specifically in elder care, that, by the way, is very unprotected, is dismantled. We don't have the resources that we need. We don't have federal, local, or state recognition. We do little things here and there for Alzheimer's disease, but we never have not even the most minimum help. Therefore, I thought this, I will have to start building systems, at least if I can handle this, building systems that are we going to offer a more cohesive approach to elder care. And we decide this number one, the first step will be to see if we will be able to bring all of these neighbors into our house when we don't even have a space to live. The office, mine, was so small that we were lacking a parking lot. 2 clinicians cannot see patients at the same time because we cannot park the cars. Therefore, we decided we will leave. And where we will go, we decided we will go to where we believe will be maybe the most central approach for what is coming. And we decided we will go to Aranza's Pass. And we built a large office. This is not done because I can talk for days about contracting and construction work. And you will hear me about this. And at the same time, we make an associated healthcare reform participation with the local hospital because we sit on the ground of Care Regional Medical Center. And I run a 10 to 12 bed geriatric unit at the hospital. And the core is this: we will provide with this location a more enhanced service, such as Dr. Quintanilla, Child and Adolescent Certified Psychiatry, will join me to provide child and adolescent service. I will continue with the geriatric one, and few of my clinicians will cover all of the adult. In inpatient, we have acute detoxification, and then we can do follow-up in an outpatient basis. And we launch a telepsychiatric center. This we will be covering many areas, in which one we provide long-term care, such as nursing home. But the project of telepsychiatry is that we will be offering psychiatric evaluation to clinic, to centers in Puero, Shiner, Kennedy, in areas in which one primary care physician have patients with memory problems, but honestly take forever for them to be connected and to receive some care. Well, about 90% of this is in place and is what we are doing, and I keep in Corpus my facing here every day because I run unit at Christus Spawn. I never left Corpus. But the most interesting part is on the last 2 weeks. This initial project took off in Victoria, and we were able to discuss with Golf Band, the MHMR of Victoria. This is very progressive, and with Citizen Hospital. And we believe that we are going to put a center in which one we will provide a constellation of different services in Victoria, but psychiatric consulting service, my practice will be providing the attachment through telepsychiatry, and all of those services will have appropriate level of consultation if it's on the hospital, or follow-up if it's in a clinic. More or less, this is where I am. I have one grandson of 11 months of age, and I am kind of regrowing with him. And I enjoy very much the feedback of this community, and I think all of this area have been embracing many of the causes, including the one of today in here. And I think this is the direction that we have to take. This is the way that we have to go. And we are facing difficult times. We are facing financial difficult times, but the elderly population of the United States should be receiving much better attention and care than what we have at the present time. Go outside and you will see the A&M Coastal Bend Agency show some flyers about some ideas what we do with our patients don't have medication, don't have coverage for prescription. With some of them doesn't have enough food for what is necessary. When some of them come, they want to see me, and they still pay in the cell, therefore they call the office, but they don't have transportation anymore. If your car breaks down, fixing your car is out of the budget. Therefore, thank you for asking, Jane.
Any other questions for Dr. Praderio? Okay, well, thank you again
Have a good
so
day.
much. So what we're going to do next, hi, I'm Jenny from the Alzheimer's Association office, and we are not quite ready for lunch.
No, not you. No, Irma, I'm over here.
Sorry, I'm like, oh, hi,
I'm sorry.
how are you?
I didn't mean to. I forget sometimes I'm in public.
So, we are we're just a few minutes, we need a few more minutes to get lunch ready. So in the meantime, we would love for you to take a break. And also, as Dr. Praderio said, all of our supporters of today's conference have tables outside, and it's really important for us for you to visit them, even if it's not something that you need right now or think you may not need. It's very important to know about resources that are available in our community and to thank them for their support, because there's no way that we could do this without them. So if you'll visit the tables, get to know them, and express our thanks, and then we'll just take a few more minutes. I'm thinking maybe by about 12:45 we'll be able to have lunch. We will eat in here. While you all are enjoying lunch, I'm going to do just a very, very, very brief presentation about the association. So we'll see you soon.